Bismillahirrahmanirrahim. Auzubillahi minash-shaytanir-rajim. My name is Dr. Tariq Masood Khan, Con.Gyn Family Emergency Specialist, Gulf KSA, working now in a district hospital as gynecologist. Will keep up CME, update by the Mother and Child Survival Group of Pakistan. A very important topic like to be discussed is the postpartum hemorrhage. This is an hemorrhage starting after the birth of the baby or after the cesarean section within the 24 hours, within 1 week and 6 weeks. Then it is known as secondary postpartum hemorrhage. There is also an antepartum hemorrhage also, which are due to the placenta previa, placental abruption and the vasa previa, and due to the local causes of bleeding like cervical erosion, growth and trauma and tears and vaginal and lesions also. Regarding the brief management of postpartum hemorrhage, is a very life-threatening condition. Sometimes it leads to immediate circulatory failure and collapse and the cardiac and the respiratory arrest. So anticipate one step before that is going to be happen. So are you ready for up till the last option? First important thing is the ABCD, BLS, Bachelor life support, and for that you have to first, it is important to inform your seniors, your elders and all multidisciplinary, multi-speciality team involvement. They should be informed, theatre to be ready, and anesthetist, senior obstetrician, senior hematologist and other persons should be on board, be standby. So you have to restate, you have to do sometimes CPR, cardiorespiratory resuscitation, because the patient can collapse at any time, and that CPR you will be doing at a rate of 30:2, 30 compressions and 2 rescue breath, and then the patient is stabilized, comes out of the crisis, and then you have to see you have to arrange the double bore wide 14 cannula, this IV lines, and then you have to use crystalloids and the colloids, and then you have to take all the bloods for all the necessary hematological, especially also for prothrombin and fibrinogen degradation products. Sometimes DIC is also a factor. Then you have to see first the options. The most important option is atony of the uterus. The uterus is not contracting at all. Sometimes there is vaginal you have to see the other options as well. The most important is the uterine atony, and for that you will be using symptometrine. Methergine before it was used was effective, but it's not used in hypertension. Then misoprostals and prostaglandin and analogs, especially E, and then uterus you can put in the infusion as well, and then you can use as pessaries in posterior fornix as well as in the rectum. Then if it is not controlled and the bleeding still continuing, then you look for the tears, vaginal, perineal and the cervicals and the lacerations and all that. And before that also you have to see the placenta is complete, or some piece is entangled, or the clots entangled inside the uterus. There can also be bleeding due to shock, neurogenic as well as hemorrhagic in inversion of uterus, which is also an emergency. Then after repairing all these and still the bleeding is continuing, be ready for the packing or the Sangstaken tube, Blaylock. You can put this in the uterus to have pressure on the bleeding vessels. And then with all these measures, the bleeding is not controlled, then shift the patient to the theatre. Meanwhile, you have to arrange 2 to 4 points of blood and all the hematological parameters platelets, fibrinogen degradation product, fibrinogen platelets, and FFP also should be attained. Meanwhile, give double IV line and infuse crystalloids and also colloids. And then you open it, the laparotomy is being done to see is there any tear, rupture of previous scar or other things, or it is simply the uterine atony. Then brace sutures are applied, and then the modified brace sutures for the atony of the uterus. Still the bleeding is not being controlled, then what you have to do is to then ready for the ligation of the arteries, uterine arteries, ovarian arteries. And then after all, if it's not being controlled, so go for ahead, ask the surgeon for the ligation of the internal iliac arteries. This saves life and saves hysterectomy. Even all these Meyers fail. Now there is another latest approach which is of intervention radiology. Bleeding vessels are sealed by the gel through the interventional radiology, UAE, uterine artery embolization, and then it is very effective, and it blocks the bleeding vessels, so bleeding is stopped. If all these measures are failed, then life-saving of patient is very important, and then you have to go for the hysterectomy, last option. All the other options you have tried and they do not work at all. Meanwhile, blood being transfused, and as for hysterectomy, what you will be doing, preferably subtotal hysterectomy. Be aware that in the pregnancy, all the areas, the parts of the uterus and the ligaments and the course of the ureters, they are all swollen or edematous. So very careful about the dissections. Subtotal is the choice, but you can also do the total abdominal hysterectomy. Check for the urine, the output, and then still if it is the bleeding is not controlled, then go for the fibrinogen degradation products. If they are high, then disseminated intravascular coagulation due to high bleeding has occurred, then you have to give fibrinogen factor 8 and 9, fresh frozen plasma platelets fibrinogen. Still the bleeding is not there, then you have to see the liver for any rupture, small rupture as in preeclampsia or spleen, and then you ask the opinion of your surgical colleagues. So this is the brief review of the important options available and the early resuscitation that is most important to save the life of the patient. So we will next time present with another review. So keep up CME post-graduation and keep praying God Almighty, always praying, loving and obeying God Almighty, and follow the lifestyle of Hazrat Muhammad sallallahu alaihi wasallam. Durood salam un par is our survival and health. So wama alayna illal bala. I end with this. कभी ए हकीकत मुंतज़र नज़र आ लिबास मजाज में कि हज़ारों सजदे तड़प रहे हैं मेरी जबीने नयाज में. Thank you very much. Jazakallah.